Hypertension can cause catastrophic complications in pregnancy. In this voiceover, we will discuss the types of hypertensive disorders of pregnancy and how they affect pregnancy. As a quick outline, we're going to discuss the most common hypertensive disorders affecting pregnancy: gestational hypertension, preeclampsia, eclampsia, and pre-existing chronic hypertension. We'll also touch on HELLP Syndrome, which is related to the hypertension in pregnancy. Hypertensive disorders of pregnancy are the most common complication of pregnancy, affecting about 10% of pregnancies. They're also a leading cause of maternal mortality and a significant contributor to neonatal morbidity and mortality. We talked a little bit about hypertension last semester. And later on this semester, you will learn about management of hypertension in the general population. But here we'll be sticking with pregnancy. Hypertension is defined as a systolic blood pressure greater than or equal to 140 or a diastolic pressure greater than or equal to 90. Gestational hypertension, formerly known as PIH or pregnancy-induced hypertension, is elevated blood pressure after 20 weeks gestation that is not accompanied by proteinuria or other signs of preeclampsia. This is the important distinguishing feature from preeclampsia. If this hypertension persists greater than 6 weeks postpartum, chronic hypertension is diagnosed. Preeclampsia is a multisystem hypertensive disease unique to pregnancy. It is defined as hypertension occurring after the 20th week of gestation that is accompanied by significant proteinuria. Now, proteinuria is defined as greater than 0.3 grams or greater than 300 milligrams of protein in a 24-hour urine collection, which correlates to a random urine dipstick evaluation of 1+ or greater. There's also edema sometimes associated with preeclampsia. It used to be one of the triad of symptoms between the hypertension, proteinuria, and edema that used to define gestational hypertension, but edema is no longer considered part of that triad as it is too nonspecific and occurs in many pregnancies not complicated by hypertension. Eclampsia is the progression of preeclampsia to generalized seizures that cannot be attributed to other causes. Seizures can occur during pregnancy, labor and delivery, and postpartum. Chronic hypertension or pre-existing hypertension is elevated blood pressure known to be present prior to pregnancy or that's detected prior to 20 weeks gestation. Unrecognized chronic hypertension also might not be diagnosed until after the end of pregnancy, at that postpartum visit about 6 weeks out. Preeclampsia affects 5 to 8% of U.S. pregnancies every year. And there's no consensus on the etiology of preeclampsia. It is a major cause of perinatal death, though. It's also commonly associated with intrauterine growth restriction in the fetus. Some of the risk factors are being the first pregnancy of the mother, mothers at extremes of age, either very young or older, multiple gestations, a history of chronic hypertension, kidney disease, lupus, or diabetes, also obesity, or family or personal history of preeclampsia. We're not going to go into full pathophysiology about preeclampsia, as the book does a very good job of it, except to say that what's thought to go on in preeclampsia involves the immune system malfunctioning, some ischemia, some oxidative stress and inflammation, along with thrombosis and endothelial dysfunction. Although the signs and symptoms do not develop until the second half of pregnancy, it is believed that the process begins shortly after conception. As far as prevention, there is no general consensus, although ACOG, the American College of Obstetricians and Gynecologists, recommends taking a low-dose aspirin, 81 milligrams per day, as it appears to have a modest preventative effect for high-risk women. Classic signs of preeclampsia include elevated blood pressure and proteinuria. You need to make sure that the blood pressure is in fact truly elevated, and patients are usually sent from the OB office to the hospital to have serial blood pressure readings taken in order to help differentiate between anxiety and true elevations in blood pressure. As far as protein is concerned, you would ideally want a clean catch specimen of urine to avoid contamination. Again, proteinuria is defined as protein greater than 300 milligrams in a 24-hour collection. Also, new onset of systemic diseases including thrombocytopenia, which is a platelet count less than 100,000, impaired liver functions, elevated creatinine levels, and new onset of cerebral or visual symptoms. Preeclampsia can be very dangerous to both the mother and the fetus. It can develop rapidly and progress rapidly, and the early symptoms often go unnoticed by women or may be attributed to another cause. So when assessing a client and educating them about preeclampsia, always ask them if they have experienced any of the following symptoms. A headache, usually the worst headache in their lives, that's not relieved with rest, Tylenol, or hydration. Also, if they're having any visual disturbances, seeing spots before their eyes. Any epigastric pain, meaning right upper quadrant pain, typically described as a constant dull ache. Why do we ask the patients these things? Well, the continuing headache, drowsiness, or mental confusion can be indicative of poor cerebral perfusion and could be a precursor to a generalized seizure. Visual disturbances, such as blurry vision, double vision, or spots, can indicate arterial spasms or edema in the retina. The epigastric pain is especially ominous because it can be indicative of liver issues and possibly warn of a seizure. There's also decreased urine output, which indicates poor perfusions of the kidneys and can precede acute kidney failure. This slide outlines for you some of the complications of preeclampsia for both the mother and the fetus. Preeclampsia is categorized as mild or severe depending on the frequency and intensity of the presenting signs and symptoms. Remember, though, that preeclampsia is a dynamic process and requires frequent reevaluation for evidence of severe features. And those severe features include a blood pressure greater than or equal to 160 over 110 on two separate occasions at least 4 hours apart, visual disturbances, pulmonary edema or new shortness of breath, abnormal liver function tests possibly associated with mid or right epigastric pain, abnormal kidney tests, low platelet count, liver abnormalities based on lab tests, and HELLP Syndrome, which we'll discuss later. The only definitive treatment is delivery, which may not be the best option if preeclampsia is mild and the fetus is very premature. Remember, a lot of decisions in OB are based on weighing risks and benefits. Does the risk of keeping the woman pregnant with preeclampsia outweigh the benefit to the fetus when she's only 30 weeks gestation? If the fetus is less than 34 weeks gestation and the woman must be delivered, the woman will likely be given steroid injections, typically betamethasone, to help accelerate fetal lung maturity. This is a series of 2 shots given 24 hours apart, and an attempt will be made to delay the birth for 48 hours. If this is not possible, due to deterioration in maternal or fetal status, the fetus will be delivered, irregardless of the time from the betamethasone. Vaginal delivery is the preferred method of delivery due to the multi-system impairments experienced by the preeclamptic mother that might be exacerbated by an operative cesarean section. If preeclampsia is in fact mild, home management is an option. In order to qualify for this type of management, both mother and fetus must be stable, and she has to be willing to adhere to a treatment plan and follow-up visits. Severe preeclampsia, defined as a systolic blood pressure greater than or equal to 160, or a diastolic pressure of greater than or equal to 110, or evidence of multi-system involvement, may necessitate delivery despite the fetus being less than 34 weeks, if the disease is severe enough and the risk to the mother is great enough. Some women can remain pregnant, but due to the severity of the preeclampsia, they have to be hospitalized with the goal of preventing seizures and maintaining the pregnancy until it is safe to deliver. The goal of bed rest is to minimize external stimuli, like lights and noises, that could potentially precipitate a seizure. Some women will be given an anticonvulsant medication. The drug of choice in pregnancy is magnesium sulfate, which we'll talk a little bit more on the next slide. Some women will be given antihypertensive medications because the risk for stroke or congestive heart failure is higher. Commonly used meds include hydralazine because of its known safety in pregnancy. It's a vasodilator that increases cardiac output and blood flow to the placenta. Nifedipine and labetalol are two other meds that are commonly used as well. During labor, the woman will be monitored continuously for signs of imminent seizure, because labor and postpartum are when most seizures occur. The mothers will likely remain on the magnesium sulfate drip for seizure prophylaxis throughout the delivery process and up to 24-48 hours afterwards. She should be maintained in a lateral position to promote good blood flow to the placenta. Pain management will be through the use of IV analgesics or possibly an epidural, as long as there's not significant thrombocytopenia. Pain meds not only help to decrease the pain, but will often lower the blood pressure as well. Continuous external fetal monitoring, or continuous EFM, will be employed to ensure that the fetus is not showing any signs of compromise. Postpartum, you need to assess the woman's blood loss and identify any signs of shock and treat accordingly. Signs that the woman is recovering from preeclampsia include urinary output of 4 to 6 liters per day, decreased proteinuria, gradual improvement in the labs, and return of the blood pressure to normal, typically within 2 weeks. Magnesium sulfate is the drug of choice for seizure prophylaxis in pregnancy. This is because it's a central nervous system depressant that blocks neuromuscular transmission and decreases the amount of catecholamine liberated. Magnesium is not an antihypertensive medication, but it does relax smooth muscle, including the uterus, and thus reduces vasoconstriction, possibly causing a modest blood pressure reduction. Although not risk-free, magnesium sulfate has a long safety record, with fetal magnesium levels being nearly identical with maternal levels. Therefore, it is important to monitor serum maternal magnesium levels to ensure therapeutic levels are reached. Most adverse reactions are associated with higher serum levels. Adverse reactions include central nervous system depressant, which is one of the most important reactions to watch for, because it can lead to respiratory depression. Other symptoms, including flushing, sweating, hypotension, and depressed deep tendon reflexes, can also be present. Nursing assessments include monitoring the blood pressure, respiratory rate, oxygen saturation, drawing serum magnesium levels as ordered, checking deep tendon reflexes, monitoring for urine output greater than 30 milliliters an hour, and watching for signs and symptoms of magnesium toxicity. Resuscitation equipment should be available, including suction and oxygen, as well as the antidote to magnesium sulfate, which is calcium gluconate, in the event there's a magnesium sulfate overdose. Fetal effects include decreased variability. Neonatal effects include respiratory depression, poor tone, and decreased suck reflex. It's important to note that magnesium must be given via a secondary line. That way, the medication can be discontinued at any time while the primary line remains functional. Severe preeclampsia can unfortunately lead to eclampsia, which is marked by the onset of one or more generalized seizures. And like we said earlier, it can occur anytime during pregnancy, labor and delivery, or postpartum. These are usually generalized seizures that start with facial twitching and then are followed by the tonic-clonic movements that can last about a minute. Breathing stops during a seizure but resumes with long, noisy inhalations, and this sometimes results in transient, non-reassuring fetal heart rate tracing due to this maternal apnea during the seizure. During eclamptic seizures, magnesium sulfate is the drug of choice. Other anticonvulsants or sedatives are not routinely given. Management is to both keep the mother safe during the seizure and afterwards. You would want to keep the side rails up and padded to prevent injury, monitor for signs and symptoms of labor. You would have a continuous external fetal monitoring, and then when the mother and baby were stable, you would deliver them. Chronic hypertension is diagnosed either based on previous reports from the patient of a history of hypertension or evidence that hypertension was present in the pregnancy but occurred before 20 weeks gestation. The most common complication, of course, would be the development of preeclampsia, which would be called chronic hypertension with superimposed preeclampsia. And this would signal not only the blood pressures are involved, you also get the appearance of the proteinuria. Management would be by more frequent prenatal visits. You would do regular fetal surveillance, which would include kick counts, biophysical profiles, NSTs, and growth scans. There are certain classes of antihypertensive medications that are safe to use during pregnancy. Methyl-dopa, beta blockers, and calcium channel blockers are acceptable during pregnancy. Contraindicated in pregnancy are the ACE inhibitors, the angiotensin converting enzyme inhibitors. Finally, a complication of these hypertensive disorders of pregnancy is HELLP Syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. Women with HELLP Syndrome present with pain in the right upper quadrant, low chest, or epigastric area. They could have tenderness on palpation from liver distension. The women may also complain of generalized malaise and nausea. They can have bruising, mucosal bleeding, petechiae, and bleeding from injection sites due to low platelets. Assessment findings are associated with alterations in the lab tests. Treatment is the same as with preeclampsia and eclampsia. The only definitive cure is immediate delivery, and depending on how severe the HELLP syndrome is, it will determine how quickly that delivery will occur. The severity of HELLP syndrome necessitates delivery in a setting that has intensive care facilities available. And resolution is usually within about 48 hours postpartum. This concludes the voiceover on hypertensive disorders of pregnancy. As always, if you have any questions, feel free to email me and I'll get back to you.